Hello and welcome to today's webinar, which is the anatomy of the unnecessary recordable outcome. We've been looking forward to this all week, and I hope that you guys have as well. We've got some great registration numbers, so we've got a lot of new faces, attendees that are here with us, and we're thrilled to have you. Just kind of give you an overview. My name is Holly Foxworth. I'm one of the registered nurses, and I'm also the marketing manager for content here at Axiom. I'm joined by our subject matter experts. We have brought in the duo CMOs today. We have CMO Chief Medical Officer, Dr. Scott Cherry, then we have CMO Chief Marketing Officer, Dara Wheeler. So before you meet them, let's talk about June. June is going to be a wild month. We've got a lot of things that are going on, and all of them can involve you. We will be at ASSP, and that's going to be June 5th through the 7th. There in San Antonio. We will also be at SURE the 11th through the 13th, and that's going to be in Las Vegas. If you do not already have expo tickets for those and you would like to have those, I think that we still have some remaining passes. You're welcome to drop your name in the Q&A chat, and we'll be happy to get you one of those after this event. The other thing I was going to mention was that we have another webinar that's going to be coming up on the 22nd, so that following week, and that is Venomous Foes, Understanding Snakes and Spider Bites. So we'll be going through how it is that you can recognize venomous spiders and snakes. We'll go through preventative measures for avoiding some of those encounters, and then also some life-saving measures, including where it is that you can find antivenom in the event that you were bitten. So we hope that you will join us for that. The way that you can save your seat right there is to press that register now button. There's a blue button that's on the right-hand side of your screen at the top. You just press that button, that'll get you registered. You don't have to enter any additional information, and we obviously would love to have you there. To give you an idea of what's right below that, you'll see that there's a Q&A box. So that's the chat box. So we love to hear from you. We like these to be very interactive and conversational. So if there's anything that you want to say, any question, there's no such thing as a dumb question. You can even make comments as well. So we love to hear from you, and that's where your name needs to be if you enjoy getting gifts. I love to send gifts after these events for those that submit some great questions. So I look forward to hearing about all of them from you. Oh, and it looks like there's some that are already taking us up on the offers for the tickets, so that's great. We can't wait to get in touch with you afterwards. So let's go ahead and introduce our panel. We'll start with Dr. Scott Cherry, and then we will move over to Dara Wheeler. Dr. Cherry?
Thanks, Holly, and good afternoon, everyone. My name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer. My professional background, I have experience in supporting the military, industrial, and government operations. I'm board certified in preventive medicine, public health, and occupational environmental medicine.
Awesome. How about you, Dara?
Thank you, Holly. Nice to be here. I am Axiom's other CMO. I am the Chief Marketing Officer for Axiom, and been with the company for almost 18 years and have loved almost every minute of those 18 years helping our clients with any of their challenges that they're facing. So really, really glad that you're all joining us today.
Awesome. Well, thank you both for being here. All right, so let's kind of go through what we'll talk about today. So we're going to get into expectation versus reality. We'll get into some of the injury and illness trends. We're going to go through some of the common mistakes that are impacting some of these outcomes, and then obviously we'll share some great stories of things that are real stories that we've encountered, and give you some solutions so that you'll have those in your pocket, especially as we're gearing up for summer. As we look at some of the expectations versus reality, I think that unless there's a unicorn in this audience that has never had an injury go south, and if you are there, please raise your hand and let us know. We'd love to hear from you what your secrets are. But it's likely that you've encountered an injury that goes south. And what I mean by going south is where you think that something is minor, but all of a sudden then you end up with, you've got a lost time on your hands, or you've got prescriptions, you've got overtreatment. It never fails that those ibuprofen prescriptions of 800 milligrams, those burn. So what we're looking at today is why that happens. What are the steps that get missed? What are the things that are overlooked? And so that's what we're really going to dig into. So I'm going to go to Dr. Cherry first and let you kind of talk through some of the workplace and injury illness trends.
Thanks, Holly. And, we're talking about both workplace injury and illnesses in a way to kind of keep them separated in your head from a definition perspective is injuries are usually considered occurring within one shift, and then illnesses are considered across multiple shifts. And so if we look over the last 3 years, what you really see is injuries are a much higher proportion of the total reported cases, almost 5 times as many injuries as illnesses over those years. And I think that's really a common occurrence. Really, injuries are the bulk of work-related incidents that we see across the board. And COVID is during this time, and so it really did shake things up. So it's hard to glean what's coming through these trends in some manner, but you can also see that in 2020 there was a dip in injuries, and that could be because of less people working, a more focus on safety perhaps, but then you also see illnesses went up. And so there's really a lot of potential co-founders here, but I think we can glean here that again, injuries are going to be at least 5 times as much in volume as compared to illnesses. And so it's a much different administrative method to deal with illnesses through workers' compensation. And so that's kind of an interesting component of it.
Wow. So did the injuries, do you have a percentage of how the injuries changed then between those reporting years, the last one that was there? They gone up?
Yes, there was a slight increase from 2020 to 2021, about a 6% increase. And so, I do think to some degree that there's a lot more work occurring. And so really refocusing on primary prevention is really key. Complacency sometimes kills, so to speak, to where everyone's excited to get back to work, or you have new employees back at work. And so getting used to a new work routine is key. So you really do want to pay attention to that.
Yeah.
Hey, Dr. Cherry, I know one of our colleagues, Dr. Tom Gilliam, often talks about muscle strength in the workplace. Do you think also if people were working from home for a time and then came back, was there a loss of muscle strength, do we think, during this time frame too?
Yes, he's put out some really good research about how things have been occurring over the decades, but even during COVID. And his work has focused on how the workforce in general has been getting weaker across different decades of life, comparing, say 20 to 29-year-olds now versus, from the 1980s. And so we do know there's a higher risk of injury and physically demanding work when the physical capacity has degraded over time. And so his work before used to kind of look at kind of long-term environmental factors, but now I think with COVID, we did see that risk of people being either off work and more sedentary. And if that was their only form of physical conditioning, you definitely become deconditioned over those months and years.
Took a hit. Yeah, definitely. Well, Dr. Cherry, I'm going to have you go through and explain what the different categories of OSHA recordability are. I know that this may be routine for some that have a safety background, but there's some others that are here that do not necessarily have a safety background. So we want to make sure that we're all on the same page in terms of language that's being used.
Sure. And, so these are the potential outcomes from a work-related injury. And so when you look at the majority of injuries, really the majority of them should be kept at the first aid level if they are being seen timely and getting effective triage and case management. And along those instances, if no other components like lost work, restricted work occur, then really that's a that is not a recordable incident. And so these last 3 will actually incur what we call OSHA recordability. And so if an injury requires medical treatment beyond first aid, then that automatically will make it an OSHA recordable, even if there's no restricted work or lost work. So you could essentially have someone go to a clinic, get a prescription, and when they come back to work, not miss a beat, it's automatically an OSHA recordable. Same thing with restricted work. And so there are tight definitions around medical treatment beyond first aid. And I can probably go over a few of them that potentially will quickly take a minor injury and put it into this medical treatment beyond first aid. So there's really a lot of value here for those who are managing injuries or the programs of injuries. But really, I think what we see a lot of times is a non-prescription medication given at prescription strength. So, Holly, you mentioned the ibuprofen at 800 milligrams. So we can all buy, 200 milligram ibuprofen over the counter. And so if that is issued and nothing else is there from restricted work or lost work, then, that would be a non-recordable injury. But again, if pain medication is given at a prescription strength, then that really is kind of like an unforced error, unless it's severe pain again. So another, I think, one is, say there's an ankle sprain and the ER doc issues a rigid splint. Any kind of rigid immobilization will actually automatically incur this recordable medical treatment beyond first aid. And these are OSHA definitions, so there's really no leniency at all. Whereas if the person could get away with an ACE bandage, then that could quickly, that makes a big difference in this outcome of recordability. With regard to lacerations, if it's a small laceration but still gets a couple of sutures, then it would be recordable. If it could be steri-stripped or butterflied, then it would not be. And so there's a lot of nuance around the medical aspects of keeping things not recordable through keeping it not going into this medical treatment beyond first aid.
Right.
And
there's been a lot of, I'm sorry, Dr. Cherry, did I interrupt you?
No, go ahead.
Oh, I was just going to say, we've had a lot of questions that are coming in. These are excellent questions. We may get to some of these as we get further along in the presentation. If we don't already cover that, then we'll come back to it. Yes, again, this recording is, this event is being recorded, and you'll get a copy of that after this event. It usually goes out within 24 hours.
Holly, I had a question for you. Dr. Cherry's talking about this experience with the prescriptions and over treatment. I know, we'll dig in a little bit more in depth. Can you talk a little bit about your experience coming from the emergency room to Axiom?
Yeah. Basically, I'll just tell you, I was part of the problem and not the solution. Prior to joining Axiom, I was probably the nurse that you were hoping you didn't have there, because not everybody's educated on what OSHA recordability is. And that's just a fact. You may get a clinic that's a little bit more specialized, but whenever you go in the ER, it's always a risk. You're always going to run the risk of nurses not understanding what recordability is, doctors not understanding what recordability is. And it's just some of these minor little bitty mistakes, like we mentioned, the ibuprofen and the amount of 800 milligrams, or went ahead and writing out a note for the employee that, they don't have to return to work. And we looked at it from a different perspective than what they look at from an OSHA lens. In the ER, you're looking at patient satisfaction, and some of those scores that come through there, they're asking, was your pain controlled? Did you feel like that you were adequately treated? So you definitely, there's a lot of minds there that could blow up when things are left unattended, for sure.
I would just add to the mindset of the ER doctors and providers. They really are expecting to see the potentially worst cases coming through the door. And then you couple it with their ability to get adequate follow-up is almost 0%. It's not like a family practice or an occupational medicine clinic. And so, they're going to really be geared to, and plus if the ER is very busy, they're not going to spend a ton of time either. They're going to really, quickly assess and then treat very firmly and potentially strongly. And so the OSHA sensitivity necessarily isn't there. Here at Axiom, we think, the right level of care is good medicine and is good business. And so just like what you said, though, Holly, though, that there's also these other soft measures about patient experience and rating customer support or customer experience, which is the patient. And so sometimes you'll see the docs actually asking, when can you return to work, right to the patient. It's not necessarily based on the position description and the severity of injury.
Yeah. And the liability as well. They're scared to death they're going to be sued if they had access to a test or a diagnostic procedure and they didn't do it. There's always that liability that's there. And so they're always going to err on the side of caution. That's why it's definitely always a risk there. Great.
Dr. Cherry, I've also heard you talk about one other aspect of that too, which is the ER doc assumes not only are they seeing the most severe, the worst scenarios, but they're also expecting to be the only time an employee potentially is getting treatment for the scenario that they're facing. And that follow-up care is unlikely. And so that's the other piece that I've heard you talk a little bit about, that it's that secondary care, that follow-up visit, that if an employee is seen in an emergency room, that doc is assuming this is the one shot to take care of this person, versus somebody who has access to case management or longer term care where they get support.
Yeah, it makes totally a huge difference if a provider feels like they can get feedback about how the patient's doing over time. And so say it's a simple abrasion or laceration, someone who has a good rapport with the doc, or if they're going to make sure they get feedback maybe in a couple of hours or the next day, they may hold off on prescribing antibiotics for an injury, because if there's no signs of infection, why give it? In the ER, if it's a laceration, it's pretty much going to get antibiotics just to cover them for anything that potentially will happen down the road. Because again, these people, the providers in the ER are not assuming to ever see them again. If they see them again, it's going to be near catastrophic potentially, right? So there really just is that gear. So I think follow-up is huge. It's a huge differentiator about the ability to see how a patient is doing over time. And I think we may talk about this with heat injuries too, but I think that's a huge benefit where you can monitor someone every hour or so. And if they're improving, that's a huge differentiator with oral rehydration versus let's get an IV in them immediately and kind of make sure they're good, So, I think just from a high level, timely follow-up is absolutely critical.
Absolutely. Yeah. Lots of good questions coming in here. A lot of questions about are people trained, between first aid and knowing how to handle higher acuity events, some of those. So we're definitely going to get into those momentarily. Dara, I'll go over to I'll let you have, or was Scott didn't take this? Either one of you. I'm sure that you can all handle it. But talk us through some of those common mistakes that we were going through.
Certainly, I think what we've seen over the years when we consult with new clients is that this list here is really what is the major driver for a lot of unnecessary OSHA recordables. Number one, lack of a defined process, I think, is really one of the main ones. If you don't have something in place, if you don't have a policy, if it's not well enforced, and if there's not continuing evaluation of that process, you can quickly have a lot of chaos into where if someone's injured and really there's no training to say you need to immediately report it to a supervisor and let's get some more information about this. Let's document it. Let's get a medical assessment quickly. That will definitely cause a lot of chaos at minimum, but it really does affect the outcomes. So again, if you don't have a process, you're most likely going to have delayed reporting in some fraction of your injuries, or probably the majority of them. And then just kind of like we were talking about with the ER, if the majority of your injuries are just self-referring to high levels of care, like in the emergency room, you really have a high chance of inappropriate level of care. And then lastly, if there's not this system in place to support the injured employee, then you're going to have really a high likelihood of non-compliance with recommended interventions.
Mm-hmm. And that happens. It happens so many times you wouldn't even believe it. That you think that you're on a good path. You think everybody understands, and then somebody doesn't take the medicines, or we're not all on the same page. So that's definitely a pothole that you can fall into sometimes. Dara's talking us through about injury process, not necessarily just that we think ours is the best. We're a little bit partial, obviously, but talk us through what that should look like and how it is that you can get that education out.
Yeah, I think Scott talked a little bit about policy and process and defining that. I think number one is making sure that we have a solution in place and a process in place before an injury occurs. I know that even the most calm person in a scenario like this, even if you're a combat vet, even if you're medical, a lot of our safety professionals out there have medical training. This is still a bad day when an injury occurs, even if it's minor. It is never a good moment. And so if you don't have effective process in place before that, and have practiced that process to make sure that it is ready and there's an easy, simple solution, then you are in the middle of a scenario that's stressful and it's panic mode, and you may struggle to think about what next steps should be taken. And so we definitely encourage having a great policy and process. Thinking about whether you handle it internally or externally, I think really considering different options out there. A lot of our clients that have joined us today, or participants today, might have internal medical teams. You might have on-site safety responders that are trained in emergency medicine. You have a lot of different solutions out there. You also have the third-party solution, like what an Axiom does. That's a telephonic triage solution. There's a lot of different ways to manage injuries, but you need to think through from a scale perspective. If you are a large organization or you have multiple locations, even if you're a small organization that has a lot of different locations or remote employees, if you've got field employees that are traveling, making sure that you've got a simple solution. If that employee is by themselves in the field or moving around, that they know what to do in those scenarios. That's really important. Do they know who to notify? Are they supposed to talk to their supervisor first? Or are they supposed to call a third-party provider? And making sure we continue to educate about that process. Axiom's found over the years that even the best organizations with the best practice around this, if you do not continuously educate, just like our safety teams out there doing their safety toolbox talks every day, every week, making sure you communicate and educate on your injury management process is really, really important, because when it does occur, you want that followed the right way. And so making sure that you continuously re-educate and train employees on this, and also make it a part of the onboarding process. If you have a learning management system, if you've got a really great onboarding process, make sure that injury management is a part of that process. Even if it only happens rarely, it is important that you communicate that with employees.
Mm-hmm. Absolutely. Absolutely. Let's talk through then the idea of delayed reporting and the impact that has on some of these outcomes.
Now, Axiom's handled hundreds of thousands of cases over the years. And so one of the things I like to talk about is that we went into business to take care of employees first. We realized that number one is care for employees. Number two, if we care for employees quickly and efficiently, then we see the outcomes managed. And so when we say a delay of reporting can increase recordability, this is held true for us in the 23 years of doing business. And we look at this critical hour. And if employees are injured and we get involved within an hour of the injury, the outcomes are phenomenal in terms of making sure the employee gets high quality care. The OSHA outcomes are improved, as well as workers' compensation outcomes and the cost associated with an injury. The reason that hour is so important is just like you would see in any sort of urgent or critical injury or scenario. The faster an employee gets care, the faster the healing process is instigated, and that the faster that employee is able to either stay on the job or return to their job appropriately. And this is, I mean, like I said, held true in all of the industries we work with and all of the years we've been doing this. The faster we get involved, the better. If you have a delay up to a day, then that will significantly increase the recordability of the outcome issues that you see with delayed reporting. And that is because of the healing pattern. It's because of the confusion or concern that the employee may have in getting care. They may have already gone to an emergency room or gotten care somewhere else that maybe wasn't the best for that injury, or wasn't the best for the organization and the outcomes that the organization would like. So one great example we like to use is a sprain strain, and we'll talk about a lot of other examples. But if somebody's got an ankle sprain or potential ankle sprain, they've twisted their ankle, if you get an employee immediately into a care process where that employee is running some first aid recommendations, they're doing some over-the-counter medication to reduce the swelling of an injury, the education you can do with an employee immediately and telling them about the path of healing of that injury is so important in the outcome. If you delay and that employee's ankle continues to swell and you start to see issues over time, then what you're faced with is an employee who may be really concerned about the bruising and the swelling on their ankle, and they haven't received the education around the expectations of that injury. And so one of the things we see by getting involved early is we're able to help educate and help that path of healing established right away, versus running into a clinic situation and potentially still ending up with the same injury care after a clinic evaluation, but you're running risk of overprescribing medications, or like Dr. Cherry said, you could end up in a splint that really wasn't necessarily needed in the short term. But having that continuous education and communication is so critical, because what it does is the whole way of this injury care, you are communicating with that employee to make sure if something does change, like Dr. Cherry said, if infection is setting in on day 2 or day 3, you have that level of care that is evaluating that level of infection and then changing the path if it's needed at that point. I'll pause. Yeah. Dr. Cherry, what do you think about that?
Yeah, and I'd like to expand on the healing process. I think that's the exact right concept we want to think about it, but just expanding into kind of both physical and kind of mental health. Obviously, the physical side is important, and you gave some great examples. But also from a medical perspective, say a person has a past medical history that may set them up for higher risk for infections with wounds, then we actually may recommend a higher level of care to ensure that they do not get infected. But at the same time, when you look at minor injuries, especially with a medical professional providing reassurance, that psychologically starts the healing process to where the person is no longer in question about their injury. So they may not be so apt to just pick up and go to an ER 2 days down the road when they're not sure what's going on with themselves. And so I think reassurance, when it's appropriate, is actually very powerful as a therapeutic that I think is undervalued and it's underdocumented, and it's across the board underappreciated. But I think really the healing process entails both. And so early intervention is our minds are not necessarily our friends many of the time, and especially if there's an incident, right? Our minds can kind of go 1,000 miles a minute just to see like what's going on. But having a medical professional give you timely early advice can set the tone for the whole injury.
Absolutely.
That's a great point, Dr. Cherry. And I think highlighting the laceration and infection example is a great one, because like you said, it could be that we suggest clinical care much quicker than we normally would. But I do think that that's the other piece. When you're considering a program for yourself and for your organization, that's part of the consideration, is who's asking the medical history questions, who's digging in. Because I've heard from a lot of organizations, they're like, oh, I can just give the person a couple ibuprofen and send them back to work. I know how to handle that. Or I'm trained in first aid, or I'm an EMT, or I'm a nurse. We have a lot of safeties out there that are nurses. The challenge becomes asking those medical history questions and digging in, where sometimes when you're working internally within an organization versus having a third party, it becomes that scenario of maybe we shouldn't be asking some of these medical history questions to ask if that employee is diabetic, and that gets really challenging. And I know Dr. Cherry's been a chief medical officer for internal corporations and organizations. And so you're running a clinic within the organization, or you're running a facility or an OCMED facility within the organization. And although you can make sure that you're asking medical history questions, it is sometimes challenging, I think, to make sure that you're putting your doctor hat on and not your corporate hat on at that point, right?
Yeah, obviously the privacy laws are very powerful, and we want to make sure they're respected. So yeah, when you're internal to the company, if you're not necessarily a medical resource, it becomes even stickier if you're going to ask, past medical history, there's obviously reasons why wounds will not heal as well based on many different things, but they can be highly sensitive diagnosis that actually the employee can, they may even disclose it at the time, but later on down the road, if there's some kind of sourness about the employment or even how the injury went or how their career goes, there could be concerns about discrimination about their past medical history, or if they're regarded as being disabled, even if they do not have a disability. And so there's a lot of Americans with Disability Act components too. And so, because they may tell someone within the organization that might be safety or HR, but if that person then tells someone else in the organization, they were not authorized, right? So you can quickly run afoul to kind of these privacy laws that, I know we're kind of going down this pretty deep, but it does beg the question about that part.
Yeah, absolutely. I love stories. I assume that you guys love stories as well. And there's not one that I love more than this one, because it just speaks volumes. I've seen some questions here in the chat about, asking are X-rays recordable and all of that. So let's talk through some of these inappropriate levels of care, and let's talk to the case study, and then we'll pick those questions back up because they fit right along with them.
Yeah, absolutely. So we had a couple of injuries that came in. Actually, we're about to hit summer. So during the summer, we see a huge spike in heat-related illnesses. And so we try to work with our safety partners and make sure that we're educating employees about how to prevent heat-related illness. But we do see a pretty big spike in heat concerns during the summer. We have a lot of our West Texas friends and some other people out there that are dealing with some pretty high heats. So we had, in the same company, two different employees. We had driver A and driver B. Driver A, the supervisor or the employee reported, and both employees reported the same symptoms: nausea, muscle cramping, dizziness, headache, and they looked to both be some heat-related illness symptoms. Driver A, the supervisor had the employee taken straight to the emergency room, forgot about their policy, forgot about Axiom. So driver B had the same symptoms. They immediately called us to manage their case, and there was a significant difference in the outcomes. So let's talk a little bit about those outcomes. Driver A was seen at the emergency department. He was similar symptoms that we talked about: nausea, headache, dizziness, cramping. They did a full workup, neurological, cardiology workup. They did a bunch of diagnostic tests, 8-hour visit, and the employee was diagnosed with a heat-related illness and discharged. The final bill of that illness was about $38,000, and it was also recordable based on the treatment that was provided to the employee. Driver B, the employee was immediately, I think, placed in the truck with some air conditioning. We started increasing the employee's fluids, suggested some over-the-counter medication to deal with some of the headache and nausea. The employee stayed on the job site. It was a first aid outcome, and after 24 hours, all symptoms resolved. Employee was full duty and all good. The final bill on that was $900. And I know that all of you out there have stories like this. This is not unusual, but what was unusual for us was that it was the same company same scenario with the same type of employee that happened almost at the same time. And so the client we were working with at this point was kind of telling us, hey, here's the best case study you could ever have, because this was a pretty phenomenal example of the difference between still really high level of care for employee B, still got taken care of, got to talk to that nurse and was reassured that he was going to be okay. But the outcomes were so drastically different.
Mm-hmm.
Yeah, this is a great example of the setting of the provider and kind of the culture of the provider. And again, this isn't necessarily to beat up the ER doc, because the ER doc is there for an emergent, like a true catastrophic emergency. So when they see nausea and dizziness, and anyone probably over the age of 35, they're going to quickly be concerned about heart attack, stroke. And so again, if there's nothing beyond the ER, right? So like when they're seeing that person, it's like, hey, they came to the emergency room. They're already declaring this to be a medical emergency versus an urgency or even just a consultation, right? And so again, and they're not going to get to be able to come back in 2 hours necessarily to see like, oh, are you feeling better after you cooled off? They may not even be thinking about work-related heat injury. That's going to be the final diagnosis after a long, scary list of the things they're most concerned about. So they're thinking heart attack, because that's what most people die in the country is going to be heart attack. And so it's always non-specific symptoms. And so again, if you can start treating someone with conservative treatments, and by the way, if they are working in the summer or, exposed to heat, then there's just a much better, efficient way to look at these in many ways. And so just to try to kind of give people the ability to look at kind of very similar cases, but very different outcomes based on the provider's kind of charge into the community, so to speak.
Mm-hmm.
Scott, I love your point. We're absolutely not here to beat up the ER docs in this. I think that it's critical that you have a medical intervention in a scenario like this. And the medical intervention, those symptoms, like you said, they could be a heart attack. And I think that's another point in when you evaluate a program like this, whether you use a company that's a third party like Axiom or however you create your program, that's another one of those critical areas. Symptom reviews could be so similar that you having to differentiate between a heart attack or heat related illness, unless you're a medical person who has been doing this and this is something you're trained in, that could be a miss. And so if you didn't have a program or you weren't sure, the ER is the right answer, because you could be saving somebody's life in that scenario. But if you have the capability to work with a third party or somebody that can help you assess that scenario and make sure that it's the appropriate treatment or the right treatment for the right situation, because maybe driver A had a history of heart disease and there was some other reason that employee should have gone to the emergency room. However, I do think in this scenario, the employee didn't, but at the same time, that is always something to consider when you're evaluating scenarios like this.
Yeah. Matthew was asking, and it's a really good question. He was saying, how is it that driver A would be a recordable? And what's not included on the slide is a few more details, which one of those, if I'm not mistaken, if I think back correctly, was they started IV fluids. And so once you start the IV fluids, you automatically, that's your first step to becoming a recordable. So from that point forward, your efforts are lost.
Yeah, we've had a lot of questions about diagnostics versus treatment. I'll let Dr. Cherry jump in on that. And you're absolutely right. Diagnostics do not constitute treatment. Correct. But fluid provided through IV as a treatment measure is a recordable. So if an employee, even if it's just like, just in case, or maybe this could be a treatment of the illness or the injury, then it becomes a recordable. If it's used as a diagnostic tool, then it's not. Dr. Cherry, could you talk a little bit about that?
Yeah, Dara, could you repeat what the specific question was with regard to diagnostics? Was there anything, or just talk about that in general?
No, we also have had a couple questions about why a diagnostic's not constitute recordability? Like, for example, an X-ray.
Oh, yeah.
Is an X-ray
Yeah.
considered recordable event?
Right.
Specific to this scenario, in this driver A, driver B, what you're missing on the piece on here, it says after multiple diagnostic tests and blood draws. That was the piece we didn't clarify that it was there was IV fluids provided.
Yeah, and if they kind of were working this person up for heart attack, they would probably initiate like the acute coronary syndrome protocol, which kind of those are going to give like prescription dose aspirin, maybe even other blood thinners, and so this will quickly kind of go kind of down that path. But you know, for more straightforward injuries, like if there's like a finger crush or a fall and there's a concern potentially about a fracture somewhere, or even a rolled ankle, there is that ability to get them to a facility just to get an x-ray. And if the x-ray is negative, rules out the fracture, then you do not kind of go beyond treatment beyond first aid. And so that's a very powerful component of it. Other components of some of this hard list of first aid is you can give a tetanus shot if there's kind of a concern for a dirty wound. But if you give any other types of vaccinations, then it would be considered treatment beyond first aid. And so,
And I think we can get into some more of this here on the best practices whenever we look at some of the best practices, but also the over-treatment. Dara, do you have that one where we were talking about a little bit more of the over-treatment? And that's a classic example of how it is that whenever you go to the ER, they don't have a choice. It's not an option. So what's your thoughts on how it is that you navigate that? By having a process that first reports?
Yeah, absolutely. Always process. I'm a process person, so definitely process. I do think there's some ways to think about this. Do your employees have access to first aid recommendations or supplies? Supplies, we get a lot of questions about what supplies should be on site, making sure that you've got that available, making sure that you've got somebody following up with employees. I do think we can't underestimate that care and that behavioral component of injuries. There is this piece around behavior and making sure that employees are compliant with recommendations. And a big piece around behavior and compliance is education and knowing what the expectations are and what the prognosis is. And I think, like I've said, even a minor injury could be the worst day for somebody. It's a bad day for everybody all around when an injury occurs. And I think sometimes we get locked into these outcome stats. They are incredibly important for organizations. Injuries cost a ton of money. It is a really tough thing to manage from an organizational level, but these are still individual employees that are struggling with an injury. And so even if it's minor, making sure that somebody's following up with the employee, making sure that the employee is getting access to care and getting support. And that support is so important. So it's that behavioral component that we underestimate, I think, in terms of the outcomes. So if an employee is getting that level of care, they feel heard, they feel taken care of. We see this time and time again within organizations that it really changes culture. It goes from somebody that has been injured to feeling really cared for by their organization to changing the culture of an organization. I know I'm jumping the gun a little bit there, but for us, it's one of the squishier things that we talk about. We talk a lot about the hard, whether it was recordable or not, treatment beyond first aid or not. Those are pretty relatively black and white discussions. But the piece that isn't, the squishier piece that we see time and time again, our friends out there right now in oil and gas has a safety culture that's well ingrained within these organizations. Other industries are not as haven't gotten to that place as quickly. OSHA had to, kind of come into oil and gas a little differently, and there's been a lot of focus on regulation within oil and gas. But other industries are starting to realize that the impact of a high quality safety culture makes a really big difference in the culture overall within the organization.
Yeah, I was just going to add a little bit to what you said about setting expectations. I think we had an epiphany years ago when we looked at even some of our just um, when we assist with motor vehicle accidents and kind of the differentiation between early intervention on those, even if it's a non-injury one, we did see that those that called in late potentially were much higher in recordability because, they get into an accident, they feel fine, so they don't call it in. The next morning, they feel like a train wreck. Their significant other is concerned. They may start, their mind is running again really quickly about what's going on. And so they'll just go to an urgent care or an ER, and then that's a full evaluation. If they were able to be called in, our nurses are very well trained about setting expectations about, yeah, you feel great now, your adrenaline's pumping. The next day you may feel much, much worse. Give us a call. We're going to call you and follow up just in case. And so when you set those expectations up front, it's that classic, an ounce of prevention is worth a pound of cure, because you're already planting that seed and you're starting that healing process, right? Even though they haven't been injured yet. And so, and then lastly, I just wanted to touch base on that last slide where non-compliance or actually it was regarding modalities. And so if they're referred to a clinic that may refer them almost part of their kind of model is physical therapy for most musculoskeletal injuries, physical therapy directed in response to a work-related injury is automatically medical treatment beyond first aid. And so clinics that really use physical therapy a lot, even for mild injuries, may, they're going to cause OSHA recordability when it may not be necessarily indicated. And so, I think these specifically are kind of what we, the title of this webinar is really that kind of the unnecessarily OSHA recordable.
Mm-hmm. Absolutely. Feels like the ones that bite the most are the Friday evening that you think that you're okay and nobody's going to say anything because you don't want to raise your hand and say, hey, I had an injury. And then you come back on Monday and all of a sudden that employee had an injury you didn't know about. Not only did they have the injury, they went to the ER because their spouse told them that you definitely need to be seen. They didn't understand they had to call a safety or a representative. And then here you are on Monday morning and you've got paperwork that says, hey, you had all of these things were done, 1, 2, 3, 4, and taking them off of work or whatever it may be, the outcome there, but your chance is gone. I love that about keeping up with what's going on, always knowing how to appropriately escalate some of those challenges. Anything either one of you want to add in addition to that before we jump into some of these questions?
I think we should jump into the questions. We've got a lot of good ones.
Yeah, there are so many good ones. All right, let's see. Let's start here. And then we had Colton was asking if an employee is on a leave of absence and they experience a physical decline in strength and are weaker, so like what we were talking about with the COVID stuff, what is the standard to follow when they return to work, holding them fully accountable to performance and efficiency metrics and quotas?
Mm-hmm. So one thing you could do, obviously you need to have a policy in place to support and apply this equivalently across your workforce, would be to do a return to work evaluation that's based on the essential functions of the job. And that may invoke a functional capacity evaluation. And so, this is a much bigger discussion, but that is I would say a best practice for those that really want to make sure their workforce is set up for success. Someone may be out for 2 weeks or a month or 6 weeks, and that's great. But, are they coming off of a heart attack, or are they coming off of a spine surgery? And, so they were, doing physically demanding work before, but now they're dramatically deconditioned. Or do they just get a bland return to work note that they show to HR or their supervisor, and they're back to kind of doing things? Because really the legal, from my understanding on the legal aspects of this is, if anything contributes to a pre-existing condition, it's still considered work related. And so, you want to make sure your folks are set up for success with physically demanding work.
Absolutely.
And Dr. Cherry, one thing we've seen a lot of recently, and I know a lot of our audience members have been really interested in, is that we have got this component that's the physical component. So as you described, making sure an employee is physically able to return to work, but there's a mental health component of return to work too that a lot of employers haven't known how to address. And not to take us down a total rabbit hole there, but you should be thinking about return to work in both, because it is a whole person coming back to work. And if an employee is physically cleared, so maybe the doc says, yep, employee is physically able to go back to work to doing the heavy lifting that they were doing prior, but maybe that employee is dealing with some other things. Making sure you address that whole person is really important, especially on return to work, because you may be putting them or them or others in danger immediately upon that return to work.
Yeah. All right. Here's a great question. I think we get it at least several times a year. All right, Dr. Cherry, Nathaniel wants to know, what about chiropractic manipulation?
Yes. So that's
Would
actually
that be recordable?
Yeah, that's clearly defined in the first aid rules. So OSHA has a list of probably 15 things that are considered first aid. So anything that's not on that list is treatment beyond first aid. But they actually address massage as first aid, but then they actually have quotes or an asterisk that physical therapy or chiropractic treatment is considered medical treatment beyond first aid.
Yeah. Here's another good one that I love. This one's from Kevin. Said, please confirm that when a doctor prescribes medication, even if it's not filled, it is still a recordable. Ding, ding, ding,
Yeah,
ding,
that's a good one too. Yeah, so OSHA specifically has opinion letters, or what's the term they use? It's explanation letters. So you can write into OSHA and get an explanation of the regulation, but there's several letters from OSHA on this, because I think in some ways they're trying to prevent maybe the company or coworkers or supervisors to prevent the actual ingestion of the medication. So once the prescription is written, it's considered delivered, because it's actually the medical provider's treatment as given at that moment. And so that's the difficulty in or the challenge, right? Is once it's written, then it's really, it can't be, you can't go back necessarily.
There's a lot of questions about how is it that we can navigate around the ER, or how do we, attendees are asking how it is that they can utilize strategies for if you have an employee that is sent to the clinic or an ER. So how is it that we're able to keep some of these, minimize the outcome, I guess I should say, in a conservative nature?
Well, I think we could probably give a kind of our experience across the years as well. So when we engage a new client, we typically see a kind of this staggering, if they don't have a process in place, they usually have the majority of their injuries going to clinics, being recordable, maybe 60 to 80%. Our lifetime, experience at Axiom is we keep the majority of injuries at the first aid level between 60 to 85%. And so I think you need a holistic approach to it. And so you obviously do not want just people going to the ER on their own accord. You want to have a system in place that helps early intervention. So as soon as an injury occurs, they're getting immediate access to triage and case management. And then I think through that system, it will, by the way, we do recommend going to the ER when it is a severe injury, yes. So our view is we keep the minor things minor. We quickly disposition the severe injuries, and that actually is also helping with the outcome, right? So if it's a severe amputation, if it's chest pain, if it's something that needs to go, then even though it's going to an ER, that's the best outcome possible, because things can always get worse quickly. And then I think the value is when there's a gray area, our years of expertise are able to differentiate between should we keep this conservative or should we get a second opinion with a provider, things like that. But I think having a holistic approach is going to dramatically help clear up the confusion, because there are times you do need to go to the ER, but the majority of times, just based on the natural history of injuries, the majority of them should be minor. But it does take a nuanced approach and a systemic approach.
Yeah. Maria was asking about how it is that we can approach our clinics and ask them to try to work with us on this. And there's some that are very, very similar to this, just to speed this process along. The way that you get around that and you're able to speak with doctors on your behalf is to have a medical person do it for you. So that's kind of where we sit. Our nurses would contact them before they got there and speak to them, kind of talk about OSHA recordability, what their work requirements are, et cetera. So I hope that answers your question.
Also, before you have an injury, to know where your clinics are that understand OSHA and work-related injuries. So just like process and policy, you should know where they are. That's one of the things Axiom does is we have our preferred clinics and we have our void clinics. Just because they're an OCMED clinic doesn't mean they're all created equal. So that's one of the things we like to think of is it a clinic that we really prefer, that works well, that understands the work impact of injuries and takes care of employees really well? Or is it a clinic that tends to push everything to physical therapy the minute you walk in the door, and that causes quite a bit of increase in cost for a client, or if it's unnecessary, for sure. So that's something that I recommend too, is having that plan of action before an injury occurs and knowing where your good OCMED clinics are in the area.
Absolutely. This gives a quick yes or no for you, Scott. This one was from Sonia that was asking, if someone sustains a significant cut and seeks medical attention where a butterfly Band-Aid is applied, would this incident be considered recordable since they visited a doctor?
I think the devils are in the details, but on face value, it sounds like this would not be recordable if they didn't use sutures. There is some nuance still in things if it's considered a significant injury just on the face of it. You do hear some extreme stories of like near amputations that are held on with tape, and then it's not recordable. So I think every case is individual, but in general, the first aid rules apply and are very plain. There is kind of this, just like OSHA has the general duty clause, they do have, if a provider still deems this a severe injury, then it is recordable. But I think that's utilized for very exigent circumstances,
Mm-hmm. Matthew was asking, what happens if we successfully manage a case as first aid, but without our knowledge, the employee goes to the ER on their own, they obtain an injection and pain medicine? Is the company on the hook for recordable when all of this was done without our knowledge and consent?
I think so. That may be a legal question, but I think so. I don't know if Dara or Holly, I don't want to, that's a tough one, but yeah, I think that happens occasionally. And that's that non-compliance that we talked about.
Right. Mm-hmm.
Yeah, there's some legalities. And I know a lot of you out there a couple of you asked about state work comp requirements, and there's definitely different ways to handle by state. There's different requirements around off-rate employees, clinic choices, or who gets to pick the clinic.
Yeah.
But yeah, if an employee is seemingly compliant and then goes off and seeks medical treatment and it kind of gets away from the case or the process, then absolutely it could become a recordable at that point, even without consent from the employer or any knowledge or management from the employer. And that's why getting involved so quickly, whoever you get involved or however you manage that, get involved immediately and set it on the right path. And it's not 100% perfect, but you really reduce the risk of an unmanaged process or an employee seeking care outside of work hours or outside of the control of the organization.
I do want to say quickly too, there's a huge nuance that even myself, I learned this a long time ago, but I didn't think I had to think about this, but you have workers' compensation system and OSHA recordability. And although they run kind of parallel, you can have all kinds of algorithms. So you can actually have an OSHA recordable injury that is not, has been refused by workers' comp. You can have a non-recordable injury that is a very costly workers' comp claim that, so you can have all kinds of permutations of this. So there's different legal rules for both sides. And so obviously we have safety and risk that kind of are working together, but sometimes they're in silos. And so you do want to make sure that you can get hung up on in your own company's departments necessarily. So you do want to make sure you're aligned and you do collaborate with risk and safety.
Thank you, Dr. Cherry. Brad Hendricks, good news. You had mentioned you were asking about visuals, pictures, feeds, et cetera. To answer your question, yes, we do offer video calls now at Axiom. So if that's something that you were looking for, please contact. Actually, we'll just reach out to you directly after this. Yeah. Okay, if you haven't done so already, please make for sure you press that blue registration now button. That'll get you ready for Spiders and Snakes for this next month. And also if you're in San Antonio or Las Vegas, while we're there, please stop by. I would love to give you a beanie and take some cool pictures with you and put you on our site. Thank you guys for attending. We appreciate you and we look forward to seeing you soon.